Afsar.
Hello, good evening. Good evening.
Good evening, Dr. Bahl. How are you?
Bas, all well, all well.
Nice to see you.
Okay, yes, after. Good evening, sir. Good evening, sir.
Nice to see you. Thank you for accepting to speak to us.
No, sir, not at all, sir. Thank you, sir. For the opportunity to
meet each other, virtually meet.
Yes, a virtual meeting. I think this virtual meeting is probably better than the actual physical conference. It's much better. We organized a few. It's much easier for the speakers as well as for the audience.
Interaction will be better, yes.
Yes, sir.
That's true. I saw there is some other program today going on, is it? Organized by PGI, heart failure or something?
So we had a bedside yesterday. That is not by PGI. That is by the Heart Failure Association of India.
Oh, okay.
So every month, one bedside is held for DM residents. So one institution normally presents, and residents from another institution are usually part of the people who are taking the exam. So it's a 1 hour, 1 hour 15 minute.
Yes. Dr. Afsar, are you there?
Yes, sir. Good evening, sir.
Good evening. Dr. Patil and Dr. Ranjan, are they joining?
Yes, sir. I have called everybody. They said they're about to join, sir. We'll start exactly at 8 o'clock.
8 o'clock, right. Just still another 2 minutes.
Yes.
I'll just be back in a minute.
Yes, sure. Please do it. Yeah, we'll start, Afsar.
Yes, sir.
We'll start. Yeah.
Yes, sir. We can. Yes, sir. Sure, sir. Yes.
Good evening, ladies and gentlemen. It's our pleasure and fortunate today that we have Professor Ajay Bahl, Professor of Cardiology at the prestigious EI Chandigarh, to speak to us on genetics of cardiomyopathies. We are all aware of the work he has done in this field, So I request Dr. Ajay to go ahead with his presentation. Welcome and start, Dr. Ajay.
Thank you. Thank you very much. And thank you, sir. And good evening, everybody. I will basically be discussing the genetics of cardiomyopathy. Just an overview. Briefly, I'll be discussing. So as we know that primary cardiomyopathies are what is often not realized, that they are largely genetic disorders. So when we think of all the common cardiomyopathies we must think of them as genetic disorder, and we must approach them in the way that we would approach genetic disorders. So if we see the AHA classification, the importance of genetics is realized in this classification, and the cardiomyopathies are classified as genetic, mixed, and acquired disorders. And if we see, the genetic disorders form the vast majority of cardiomyopathies. All the hypertrophic cardiomyopathies, the ARVCs, the non-compactions, and of course the storage disorders and mitochondrial disorders. Now, as far as dilated cardiomyopathy are concerned, around 20 to 50% are inherited, and around half the idiopathic restrictive cardiomyopathies, these are also inherited disorders. The pure acquired disorders are basically inflammatory cardiomyopathies, peripartum cardiomyopathy, and tachycardia-related cardiomyopathy. But it's important to realize that most of the cardiomyopathies are by and large genetic disorders. So if we see DCM, around 20 to 50% are inherited. HCM, all are genetic disorders. Restrictive cardiomyopathy, the idiopathic variety, around half of them are inherited disorders. And of course, that is why the genetics in these disorders is very important. So now genotyping is very freely available, and over the last 20 years, I'll discuss how easy genotyping has become, and it is rapidly becoming available, and the cost of genotyping is really coming down, and physicians across all disciplines are going to encounter patients with sequence variations. It's not just cardiomyopathies or cardiology. Genotyping is being carried out across all medical specialities, and the basic principles that apply to cardiomyopathy would probably apply to all the disorders. So the only thing is that when we find a sequence variation, this is the biggest problem that we face. We really don't know the significance of the sequence variation. The cost is really coming down. Therefore, we must be aware of the pros and cons of the data that we get when we are genotyping cardiomyopathies. So it is very important to understand, because all of us are different genetically. So I will differ from you and from everybody else who's present. So we must remember that there is no normal human genome. We are all mutants. There'll be differences in all of us. And many of the sequence variations that we encounter, we really will not know the significance of the sequence variations, whether they are just normal variations or whether they are disease causing. And this is where the whole problem arises. The problem is that in cardiomyopathies, the genetics is very complex. Each family may have its own specific mutation. I'll come to this later in the talk. And the clinical decisions are based on very little information about a given mutation. So if you are genotyping patients, you will realize that whatever mutation you get, except for very few, in a majority, there are just 2 or 3 families or case reports that are available. So the clinical decisions that you're making are basically based on very little information about a given specific mutation. Many of the mutations are novel mutations. They are unreported, or it's only case report. And we must remember that many of these are just simple sequence variations. That means they are not disease causing. They may not be pathogenic. Therefore, we need to build up a good database, especially of Indian patients, where we get to know more about the mutations that are present in Indian patients. What about the mode of inheritance? By and large, most cardiomyopathies are inherited in an autosomal dominant pattern. A few are X-linked. Some rare are autosomal recessive, and there is also mitochondrial inheritance. So what are the genes mutations in which generally cause these disorders? So hypertrophic cardiomyopathy is sarcomeric genes. Restrictive cardiomyopathy is also sarcomeric genes endorsement. There's a big overlap between these two disorders, between restrictive and hypertrophic cardiomyopathy, and I'll come to this. Dilated cardiomyopathy is more complex in the sense there are a large number of pathways that can cause dilated cardiomyopathy. This includes sarcomeric genes. In addition to that, we've got the cytoskeletal genes and we've got transcription factors also. ARVC is due to desmosomal gene mutations, but we must remember that these are overlapping disorders and there are several new pathways which have been described in a relatively small number of patients. So how is genetic screening normally done? So we would extract the DNA from a blood sample. This is what we did initially. This is what we were doing around 15, 20 years back, or maybe at least in our setup, maybe as recently as 7 to 8 years back. That we do exon by exon sequencing of every single gene. So this is very time consuming because sequencing was time consuming and expensive. So we would do a screening method like a SSCP, which is a single standard conformational polymorphism. This required a huge effort. You could screen only a few genes and it was time consuming. In fact, if we would screen all the genes that we are screening today, by this traditional Sanger sequencing, the cost would come to around almost 80-90 lakh rupees per patient. And with the next generation sequencing, the cost, we are getting it done to as little as around 15 to 20,000 rupees per patient today using the next generation sequencing. So this is a very major change that has happened. This has happened only in the last 15 years or so. So 15 years back, doing all the genes that we are doing was prohibitively expensive. And with the availability of next generation sequencing, the cost has come down to as little as around 15,000 or at the most 20,000 rupees today. So the next generation sequencing, we can do panels of maybe 100 or 80 or 90 genes, selected genes, or we can do a whole exome sequencing. So in 2021, we can detect a large number of sequence variations at a relatively low cost, and this cost was prohibitive as recently as around 15 years back. But the biggest drawback of the next generation sequencing is that our ability to identify mutations or sequence variation has far outstripped our ability to interpret its significance. In each given individual, we can find 100 sequence variations. Out of these 100 or 150 sequence variations, we might find 5, 7, 10 within the genes that are known to cause cardiomyopathies. But what is the significance? That is where we lack, and that is where the biggest problem is. Like you would get a report of, let us say, troponin I, arginine 145 tryptophan. So what do you do with this? You search the literature. If you find something, well and good. If you don't find something, how do you proceed? So this is what is the importance of genotyping. It is important to keep a clinical perspective whenever we are prescribing somebody, advising somebody to get a genotyping done. So is genotyping clinically relevant? Yes. For screening families, it's important. For prognostication, not so. There is no evidence to support that a given mutation affects the prognosis, except in a few selected genes. Does identifying a specific mutation change the outcome? Not really. So it doesn't really help in predicting the outcome. Does it help in predicting the phenotype? Only partially. It is very useful in clarifying an uncertain diagnosis. If you're not certain of a diagnosis and you get a known pathogenic mutation, you can reach a specific diagnosis. And the most important thing is that we get an insight into the pathophysiology. So as we know that hypertrophic cardiomyopathy is a disease that is caused due to mutations in the sarcomeric genes. And this is what was traditionally described. Myosin binding protein C, late onset disease and relatively benign. Myosin heavy chain, early onset disease, some mutations are malignant that is causing severe disease, whereas some of the mutations were benign. Troponin T was traditionally said to cause mild hypertrophy with severe disarray and high risk of sudden death despite a mild hypertrophy. And troponin I in the Japanese was said to give rise to an apical variant. So we carried out a study in which, this was an earlier study. And what I want to emphasize is that the data, all this data of severe disease, mild disease is based on very small number of patients. Like this one, if you see 17 carriers with 7 different mutations. So based on these mutations, they were classified as benign, intermediate, and malignant. So now if you have only 17 mutation carriers carrying 7 different mutations and you classify them as benign, intermediate, and malignant, I'm sure the conclusions that you draw will be very weak, they will be strong, and they're likely to be wrong. So we carried out a study on around 748 consecutive families with hypertrophic cardiomyopathy. We screened them for mutations in the troponin I gene, and what we found was that the incidence of troponin I mutations in hypertrophic cardiomyopathy was around 3%. After we went for these families, we got 100 mutation carriers, and we found that the overall disease penetrance was around half. Around half the mutation carriers manifested the disease. But what we found was that there was an age-related disease penetrance, which means that as you keep following up the patients, by the time they reach the age of 70, all the mutation carriers have the disease. So the disease penetrance is age-related. That means if you screen at 20 years, you're going to have a lower penetrance. By the time you reach 70, the penetrance reaches almost 100%. And what we saw was that within troponin I, there was practically every type of disease that was seen. The traditional asymmetrical hypertrophy, the apical hypertrophy, mid-cavity obstruction, biventricular hypertrophy, dilated cardiomyopathy-like picture, that means a LV systolic dysfunction, and a restrictive cardiomyopathy picture. So within the same gene, troponin I, we were able to show absolutely every phenotype of hypertrophic cardiomyopathy that has potentially been described. So what we concluded was that troponin I mutations are extremely heterogeneous even within families. That means one family member has one manifestation, another family member may have a different manifestation. There's no specific mutation or gene-specific pattern. There is a variable age at diagnosis. And so what it means is that if you screen a person at the age of, let us say, 20, 30, and 40, and the ECG and echo are normal, you cannot be certain that he will not develop the disease, let us say, at the age of 50 or 60. So it needs a lifelong follow-up. There is some data to indicate that myosin heavy chain mutations may be a little more homogeneous. So troponin T mutations, now let's go from troponin I to troponin T. They were described as giving rise to minimal hypertrophy with high risk of sudden death due to a high incidence of myocyte disarray. And again, if we see, this conclusion was based on an autopsy series of only 9 patients. And when you go on to autopsy series, obviously you are looking at the most severe form of the disease. So troponin I mutations, what was seen was that there was less hypertrophy in troponin I as compared to myosin heavy chain mutations. Average life expectancy was relatively low in this series. There was a high incidence of sudden death, but then there are certain drawbacks in this study. This study found a troponin T mutation incidence of 15%, whereas we know that the actual incidence is only 3%. So obviously there are biases in this study. So as we realize that most of the data that we read or what we find is based on relatively smaller number of patients. So now myosin binding protein C is traditionally described as a disease with relatively late onset of disease. If you see they are all in the older age groups. But if we see that troponin I also, you find that a significant number of disease manifestation occurs in the older age group. And if we compare myosin heavy chain and myosin binding protein C, these graphs, survival graphs, are identical. The only issue is that everything is 20 years later. So what you find at the age of 40 in myosin binding protein C may occur a little earlier in myosin heavy chain. So traditionally in probands, what was described was that with early onset disease, clinical screening was recommended only till 40 years of age. No longer holds true. If you are going to do a clinical screening, then a lifelong screening is required, because disease can manifest even later in age. And this is where genetic screening is useful. If you find a mutation in the proband and you find that the family member does not carry the mutation, you can tell him that he's not at risk of disease in future. This you cannot do by clinical screening. Clinically, ECG and echo are normal. You cannot tell that individual that he will not develop disease in future. So if we go by the ACC as well as the ESC guidelines, there is nothing called benign and malignant mutations, and finding specific mutations except for very few specific ones does not indicate the risk. So the next topic that I will come to is a restrictive cardiomyopathy. So as we know that hypertrophic cardiomyopathy has two major clinical manifestations. One is the hypertrophy and the other is a diastolic dysfunction. We know that hypertrophic cardiomyopathy is a disorder of diastolic dysfunction. And what is restrictive physiology? It is a severe diastolic dysfunction. So if we look at this figure, what we can see is that a hypertrophic cardiomyopathy patient may have normal LV wall thickness to very, very severe hypertrophy. So from left to right, the hypertrophy is increasing. And we traditionally in an adult, we would say that 13 millimeters or more of LV wall thickness is considered to be hypertrophy. So anyone with less than 13 would be, one would say has normal LV wall thickness, and 13 and above, one would say that there is left ventricular hypertrophy. Similarly, diastolic dysfunction. Hypertrophic cardiomyopathy patients may have mild diastolic dysfunction or they may have severe diastolic dysfunction. What is restrictive physiology? The most severe diastolic dysfunction. So these form around 1.5% of the hypertrophic cardiomyopathy cohort. So 1.5% of the hypertrophic cardiomyopathy have severe diastolic dysfunction, which classifies them as a restrictive physiology. So what is idiopathic restrictive cardiomyopathy? It is the commonest form of restrictive cardiomyopathy that we encounter. We must remember that idiopathic hypertrophic cardiomyopathy, sorry, I would like to go back one slide. So if we go to this, what is restrictive cardiomyopathy? Restrictive cardiomyopathy is restrictive physiology. The small number, 1.5% patients who have very severe diastolic dysfunction or restrictive physiology, if they have normal or near normal LV thickness and they have a restrictive physiology, we will use the term idiopathic restrictive cardiomyopathy. If they have left ventricular hypertrophy along with the restrictive physiology, we will use the term hypertrophic cardiomyopathy with a restrictive physiology. So a person who has a 12 millimeter septal thickness, we will say has idiopathic restrictive cardiomyopathy. Somebody who has a 16 or 17 millimeter LV wall thickness, we will say hypertrophic cardiomyopathy with restrictive physiology. So we must remember that idiopathic restrictive cardiomyopathy and hypertrophic cardiomyopathy are very similar disorders. It's just a few millimeters of LV wall thickness where the difference is there. So that's what I'm trying to emphasize. Sarcomeric mutation, no hypertrophy, is idiopathic restrictive cardiomyopathy. If left ventricular hypertrophy is present, we would say that is hypertrophic cardiomyopathy with a restrictive physiology. So it was first reported that restrictive cardiomyopathy is due to troponin I mutation. This was reported in 2003 in a Caucasian population where 6 out of 9 patients with idiopathic restrictive cardiomyopathy had mutations in the troponin I gene. So we also carried out a study where we looked at a restrictive phenotype in our cohorts with hypertrophic cardiomyopathy. We looked at around 1,200 patients of hypertrophic cardiomyopathy, and what we found was that with mild LV wall thickness. So it was 1,200 with a LV wall thickness of 13 to 15 millimeters. And what we found was that around 1.5% of this HCM cohort had restrictive cardiomyopathy. And what was seen was that the patients who had a restrictive physiology, they had worse outcome. They were sicker, they were worse NYHA class, they had a poorer survival, a high incidence of atrial fibrillation, and a poorer exercise capacity. So we screened, we were able to genotype 15 of these 16 families. We didn't have the DNA from one family. And what we found was that troponin I mutations were present in 4 and myosin heavy chain mutations were present in 4. We did not find mutations in troponin 2, tropomyosin, or myosin binding protein C. So what we see was odd myosin heavy chain. It's one of the commonest mutations that gives rise to hypertrophic cardiomyopathy. But what we found odd was a very high incidence of troponin I mutations. So troponin I mutations are overrepresented in patients who have a restrictive physiology, whether it is idiopathic restrictive cardiomyopathy or whether it is a hypertrophic cardiomyopathy with a restrictive physiology. So I'll just describe one of our families. So this girl came to us and she had a LV wall thickness of 17 millimeters. So she would be classified as hypertrophic cardiomyopathy with a restrictive physiology. Her father died at the age of 47 from progressive heart failure. He had a normal LV wall thickness, so he would be idiopathic restrictive cardiomyopathy. And her elder sister had sudden cardiac death at the age of 16 years. She also had an idiopathic restrictive cardiomyopathy. So this is a place where genotyping is useful. Like this mother came to us asking whether this son is at risk of getting this is a restrictive cardiomyopathy in future or not. And this is where genotyping comes in. He was only 12 years of this age. His ECG and echo was normal. So simply using clinical screening with ECG and echo, we could not tell her whether he is at risk of disease in future or not. And this is where genotyping is useful. So this is the echo of that girl. We see typical restrictive cardiomyopathy. We can see biatrial enlargement, which is typical of a restrictive cardiomyopathy. The endomyocardial biopsy done in the father, although he had idiopathic restrictive cardiomyopathy, shows typical myocyte disarray that we would see in hypertrophic cardiomyopathy, which means that the histology of restrictive and hypertrophic cardiomyopathy is identical. And we found a mutation in this girl. This was a troponin I mutation, and there was only one previous report of this mutation, which was a de novo mutation in a Caucasian who had a restrictive cardiomyopathy. So we found mutations in myosin heavy chain, as I have described earlier. So idiopathic restrictive cardiomyopathy. What is idiopathic restrictive cardiomyopathy? Sarcomeric gene mutations are seen in around 1/3 to 2/3 of patients in different series. Troponin I mutations are disproportionately high. Myosin heavy chain mutations are also common, and some mutations are specific for restrictive physiology, as the one that we found in our patient. So this is where the importance of genetics comes in. We screened the brother and he did not carry the mutation. So we confidently told the mother that he is not at risk of disease in future. And sure enough, in fact, this boy came to us for screening maybe around a week or 10 days back, and both his ECG and echo were normal. So what is idiopathic restrictive cardiomyopathy and hypertrophic cardiomyopathy with restrictive physiology? It is just a question of name. So if there is hypertrophy, it's HCM with restrictive. If there's no hypertrophy, it's idiopathic restrictive cardiomyopathy. But we must remember that they are at least genetically and morphologically, that means on histology, these are identical disorders. So what is in a name? 50% of idiopathic restrictive cardiomyopathy are due to gene mutations. RCM and HCM are very similar etiologically in these patients, and different terminologies only reflect some differences in the LV wall thickness. Around the remaining half of the idiopathic restrictive cardiomyopathy patients, we really do not know the mutations which are causing these patients, and these are still truly idiopathic, but around half are due to sarcomeric gene mutations. So what about conduction system disease? So if we have got hypertrophic cardiomyopathies, some of them have got conduction system disease. So if they have conduction system disease, what does it imply? So we screened 100 consecutive patients with hypertrophic cardiomyopathy for mutations in the PRKAG2 gene. We did not find any mutation in these HCM patients. Whereas when we screened 100 patients HCM with some conduction system disease, which included bundle branch blocks, etc. I'm not necessarily talking about complete heart blocks or pre-excitation. We found 2 families with PRKAG2 mutations. So on screening these families, we were able to find 45 carriers of PRKAG2 mutation. This is basically a glycogen storage disorder. And whenever you get a hypertrophic cardiomyopathy patient, or you get a patient, it's not really a hypertrophic cardiomyopathy because this is a storage disorder, so it's different. Whenever you get increased LV wall thickness with some conduction disorder or pre-excitation, the patient has a heart block, a high degree AV block, or progressive blocks, in the sense you do one ECG today and you do another ECG after 3 years, you find that the QRS has widened. In these patients, one must suspect glycogen storage disorders rather than hypertrophic cardiomyopathy. They usually occur in younger individuals with a mean age of diagnosis of 24 years. It's got a very high disease penetrance. That means by the time they reach the age of 18, almost all will have an abnormal ECG. At presentation, pre-excitation is present in around 16%. Bizarre ECGs are seen, and atrial fibrillation also may be present. So this is one of our patients with PRKAG2 mutation. As you can see that he has a pacemaker implanted and he has a complete heart block with all pace beats. So around close to 40% will require pacing by 40 years of age. Small number have got proximal myopathy, and glycogen storage disorders may be due to PRKAG2 mutations or LAMP2 mutations. So hypertrophic cardiomyopathy blocks suspect glycogen storage disorders, although some of the hypertrophic cardiomyopathy patients also may have blocks, but glycogens, if you are screened for glycogen storage disorders, in a very significant number of these patients, you will find a glycogen storage disorder. So I'll just describe one of our patients with LAMP2 mutation. So look at the ECG which was done in 2017 and an ECG done 4 years later. We can see that the QRS has progressively widened. So in 4 years, we can see that there is a definite widening of the QRS, and you can see that some more notches have appeared. The upstroke of the S wave, you see, has widened. So there is a progression of the ECG in these patients. So now let's come to dilated cardiomyopathy. So traditionally, dilated cardiomyopathy was most commonly described due to mutations in 3 genes: myosin heavy chain, lamin AC, and dystrophin mutations. Now, one thing about dilated cardiomyopathy is that there are several studies which have looked at what percentage of dilated cardiomyopathy are inherited disorders. And studies which are based only on taking a history from the patient have given an incidence of dilated cardiomyopathy of only familial dilated cardiomyopathy of only 1 to 2%. But when you carry out echo studies, that means you screen all the first degree relatives, this incidence increases to 20 to 50%. So DCM patients, we must not rely on the history. If we get a patient with dilated cardiomyopathy, we must advise that the first degree relatives should be screened, because history is not reliable. We must screen the first degree relatives using at least a ECG and echo. And these are the 3 traditionally described genes in which mutations commonly cause dilated cardiomyopathy. But in NEJM, this paper was published which showed that titin mutations are the most common inherited cause of dilated cardiomyopathy, and these are found in 25% of familial cases of dilated cardiomyopathy. 1/4 of them will have titin mutations, and sporadic cases, almost around 1/5 of them will have dilated cardiomyopathy. Of course, subsequently, some of the mutations described in this paper have been shown to be benign. So probably the incidence is a little less than what has been described in this paper. But what was seen was that the penetrance after the age of 40, the penetrance by the time these patients reached the age of 40, the penetrance was 95%. So titin mutations have got a fairly high penetrance, but the penetrance at the age of 40. So titin, we know, is the largest human protein with approximately 33,000 amino acids, and it causes a wide variety of disorders, including involving the cardiac and the skeletal muscles, hereditary myopathies, tibial muscular dystrophy, limb girdle muscular dystrophy. So it's commonly involved in several disorders. So so what about the troponin mutations causing dilated cardiomyopathy? So we screen troponin T and troponin C mutations in 235 DCM patients, out of which around 40% were familial. Familial means more than one first degree relative had dilated cardiomyopathy. And what we found was that around 5 of them had mutations in the troponin complex, and the penetrance was 100%. So since we are at dilated cardiomyopathy, I just want to emphasize one important point, that dilated cardiomyopathy patients very often recover on medical management. But can we predict who are the patients who will recover? Then we must remember that many of these patients, recovery and relapse is very important in dilated cardiomyopathy patients, because many of the patients who have some recovery tend to relapse. When does this relapse occur? Can we predict which patients will relapse, and can we prevent the relapse that occurs in recovered patients with dilated cardiomyopathy? Of course, now if we look at the classification of dilated cardiomyopathy, of heart failure, recovered patients with dilated cardiomyopathy have now been included as a separate category. So we looked at 188 dilated cardiomyopathy patients who are on guideline-directed medical therapy. At that time, this is pre-sacubitril valsartan era. So this included ACE inhibitor, ARB, beta blockers, and spironolactone. They had practically no device use. So this is pure medical management. Around 60% did not recover. But what we saw was that around 40% recovered to a LVEF of more than 40%, with an increase of LVEF of at least 10% from baseline. So if we take recovery to be 40%, then around 40% of patients recovered. And what we see is that at least these 3 drugs, if you run dedicated clinics, then many of these patients will have a high compliance, or at least high prescription of the standard drug therapy which are given for cardiomyopathy. And the only variable that we found with recovery was a short QRS duration. That means patients who had a wider QRS had a less predictability of recovery. 12% of patients in the improved group had LBVV as compared to 31% patients in the non-improved group. So if we look at other studies which have predicted recovery, a higher systolic blood pressure and absence of left bundle branch block have been shown to predict recovery in patients with dilated cardiomyopathy. Some other studies have shown shorter duration of DCM, smaller amount of LGE, a higher myocardial edema have also been shown to predict recovery in some other studies. So, but we must remember that recovered patients are not normal, even if the EF is around 50-55%. Recovery means only recovery of left ventricular ejection fraction. What may not recover is some of the ECG changes. There will be some residual fibrosis within the myocardium. There will be some degree of residual valvular regurgitation, and there might be an increase in the left ventricular and right ventricular dimensions as compared to the baseline. And these patients are at a risk of relapse and with a relatively high morbidity and mortality. So after recovery, we further followed up these patients who had recovered. We followed them for another 3 years, and we found that over 1/3 of them relapsed. And majority of the patients had a relapse after 5 years of follow-up. So it's very important. I'll just give an example of one of our patients. She was a young girl. She had dilated cardiomyopathy. She recovered. Her EF came to around above 55% persistently for several years. It was hovering between 55 to 60%. And it's very difficult to motivate patients to continue drug therapy for a long duration. So after 10 years of recovery, the parents, they decided to stop the drug therapy. And within a year, she had a relapse, and ultimately she required a heart transplant. So it's very important to tell the patients that you must continue, even recovered patients must continue drug therapy indefinitely. Basically, indefinitely means lifelong. And it's important to motivate these patients to continue drug therapy long term. As we can see that recovery keeps on increasing with passage of time, and we can see that relapse also keeps on increasing with the passage of time. So only variable that was associated with relapse and recovery was with recovery was shorter QRS, and with relapse was a longer QRS duration. And if we see the outcome of relapse patient, it's as bad as the not improved group. In fact, it's probably a little worse than the not improved group. So patients who improve have got an excellent outcome, but the patients who relapse have a relatively poor outcome. So other studies have also shown a relapse rate of between around 20%, and discontinuation of medical therapy has been shown to be a very important predictor of relapse. So 60% patients who discontinued medical therapy relapsed, as compared to only around 6% who did not discontinue medical therapy in this study. So the last thing that I will cover is, are cardiomyopathies in India any different as compared to the West? And do we have any hard data to suggest that Indian cardiomyopathies are different? So sequence variations that we know, if you look at the genetics, the genetic depends on a founder effect. So there is one given person who develops a mutation, his parents are normal, so the mutation will occur for the first time in a given individual. So when we say this person will have a mutation, his parents are normal, he develops a mutation, and he passes it on to his children. So his descendants will carry this given mutation. So the founder in Indian and the Western population is going to be different. And we have a lot of novel mutations in which we need to build a database. So I'll be discussing a few specific mutations which are common in Indians and which are not found in the Western countries. And this was a disease variation which was found, a deletion in myosin binding protein C, which is only found in South India. This is a 25 base pair deletion in intron 32. So it's not in the exon, it's in the non-coding part of the DNA. It's in the intron, which causes skipping of the subsequent exons, and it affects the structure and the function of the myosin binding protein C. As we can see that it's found all over India except the Northeast. It's found in practically every part of India, and it's got a very high incidence of mutation. And if we see, it's found only in South Asia. Even in Malaysia and these countries where it is found by and large in the Indian population, people of Indian descent. It's absent in every other population in the world. And this is associated with heritable, was found to be associated with heritable. This was a study which was done in CCMB Hyderabad, and this was found to be associated with the heritable cardiomyopathies. The prevalence of this sequence variation is very high, 4% of Indians. So you can imagine 130 crore populations, 4% is a huge number that carry this sequence variation, and it gives an odd ratio of around 7 of a risk of cardiomyopathy. And in this study, it was found that there is an age-dependent penetrance. So why is it so common in the Indian population? And this really describes the genetics of all disorders, including cardiomyopathies. As we know that porphyria is very common in South Africa. It's found in a very large number of South Africans. How did it come to South Africa? From one given individual. So only one individual who migrated from Holland to South Africa carried this mutation, and his descendants have subsequently spread it to such a large number of people in South Africa over generations. Why is it so? So that has happened over 300 or 400 years. When did this mutation occur? This is estimated to occur around 33,000 to between 23,000 and 33,000 years back, right? So this arose in the Indian subcontinent, and over these thousands of years, it has involved 4% of the Indian population. So a mutation which has occurred only one generation or two generations back, it will involve only a small number of patients. A mutation that has occurred, let us say 20,000 years back, involves 4% of the Indian population. North India, South India, West India. It involves every part of India except the Northeast. But what is the significance of for an individual population? Probably not too much. It's such a common, it probably just slightly increases the risk of cardiomyopathy. And why is it common in Indian population? Does it confer a survival benefit? We don't know. So there is another paper which has subsequently been published in JAMA in 2018. And this is where genetics says that there's so much uncertainty, and this paper brings out the uncertainties that we see. What they found was that around 10% of these carriers which carry this mutation also have a novel variant. This is the one that is probably disease causing. And this variant is in tandem and on the same allele as myosin binding protein C deletion. So one of the descendants of the myosin binding protein C deletion developed this mutation. Very close, they both are on the same gene, so they're right next to each other. And this mutation occurs only in the presence of this myosin binding protein C deletion. So probably the risk of cardiomyopathies that is associated with this deletion occurs mostly in individuals who also carry this second variation. So this is something that is common, and this is seen only in Indians. This is not seen in any population other than the Indians. So people, the person who carry both the variations have a hyperdynamic LV performance, resulting in an unfavorable energetic states. And therefore, this has been postulated, this has still not been clarified, that probably the second variation, that is aspargine 389 valine, which is associated with the deletion, is the one that is for the increased risk that is attributable to this deletion. So as far as we are concerned, these are the two commonest sequence variations that are associated with cardiomyopathy in the Indian population. So to conclude, genotyping plays an increasing role in the cardiomyopathy management. We must remember that recovered DCM patients need a comprehensive, detailed clinical assessment, not just assessment of LVEF. Despite guideline recommended therapy, some of the patients will relapse. The duration of therapy has to be, even in recovered patient, has to be lifelong. Thank you very much.
Thank you, Dr. Ajay, for that masterly presentation, and I think most of it was your original work. Thank you very much. It was an excellent presentation. And any questions from our student colleagues? Ajay, I just want two questions from my side for my information. You mentioned about the intronic deletions in the Indian South Asian population. What is the genotypic presentation of these patients?
So actually, what was, I'll just tell you how this study was carried out. So this study was basically carried out at CCMB Hyderabad, and they took sample from multiple centers in India and in different centers from different countries also. So like the study that from the Chandigarh side we did, we included dilated, hypertrophic, and as well as restrictive cardiomyopathy patients. And this was across all centers. So this is a mixed population of cardiomyopathies. It's not a specific cardiomyopathy. But it was found that the risk for every cardiomyopathy was around 6 to 7 times in carriers of this phenotype as compared to the general population.
And you also made a very important point that the dilated cardiomyopathy patients, when they recover or improved ejection fraction, heart failure, we should continue medicines indefinitely. We should not stop it. I think we should extrapolate this to even patients who have peripartum cardiomyopathy. We see quite a lot of them and quite a few of them who recover fully, but I think we should continue treatment. What is your view on that?
So this was a gray area as far as continuing a medical therapy was concerned in dilated cardiomyopathy. But now there is enough evidence, and now indefinite medical therapy has now been brought into the standard guidelines as far as dilated cardiomyopathy is concerned. Now, peripartum cardiomyopathy, the guidelines are still not very clear on this. Probably patients who recover very rapidly. I mean, when we look at a cohort, there are patients who recover within 1 month of delivery, and their LV size is normal, and many of these have got hypertensive pregnancy PIH, pregnancy-induced hypertension during pregnancy. I think probably for these patients, one can discontinue therapy after 1 year. But patients who have any residual mitral regurgitation, there is an increase in the left ventricular size, probably therapy should be continued lifelong.
I think there's one question in the chat box. Dr. Afsar, do we have to screen all the family members of patients with hypertrophic cardiomyopathy, restrictive cardiomyopathy, and dilated cardiomyopathy probands?
So, sorry, sir, I didn't get the question. I'll just...
The chat box, if you open.
I'll just go to the chat box. Sorry. Just need to enlarge this.
Okay. Do you want me to read it out?
No. Sorry, sir. Actually, I'm just trying to enlarge the. Actually, I'll just reduce. Sorry, I have to stop share. Then I can enlarge it. Sorry, that was the reason. I'll just go to the chat box. Yes, sir. As far as screening the family members is concerned, we should screen the first degree relatives. That is definitely recommended, because especially in hypertrophic cardiomyopathy, the first manifestation can be sudden death. So we must not miss out asymptomatic. So there in hypertrophic or in all these cardiomyopathies, there are two situations. First is clinical disease. That means if they have abnormal echocardiography, these patients have to be risk stratified as per the disease that they have. We have to risk stratify them whether they have sudden death, the way we would traditionally do it. The second group of patients are who carry the mutation, but they are normal. So as far as these patients are concerned, so far sudden death has not been reported in these patients, and the guidelines are that if a genotype positive patient is there who is ECG and echo are normal, we do nothing about it. We just keep these patients under follow-up. Once they develop clinical disease, then we risk stratify them. Only thing is we can advise them that don't get into a profession where you may have to leave the profession, something that involves heavy physical activities like sports and all that. Now the third group of patients is patients who have an abnormal ECG and a normal echo, because very often the ECG manifestation occurs before the echo. So in these patients, the guidelines or the data is a little borderline, but probably except for troponin T mutations, these patients are really not at risk for sudden death. So this is a gray area, abnormal ECG, normal echo. But first degree relatives have to be screened.
And just another 2 points. This so-called strain imaging, global longitudinal strain, has it made any impact in this field?
I don't think so, sir. I mean, it's a sensitive method. I don't think that we can use it to make a diagnosis, because it has not been shown that patients who have a normal echo, LV wall thickness or echo, and an abnormal strain, whether they are at risk for sudden death or not. I think there's not enough data on that. So,
in the follow-up of dilated cardiomyopathy, where they improve and you measure that they're normal, does that give any hint to stop medication?
I guess, sir, it probably would, but I don't know how much. I don't know how much would it contribute to the prognosis or something of that sort. Maybe it's not been tried. I don't know, but like peripartum cardiomyopathy, if you want to stop therapy, maybe you can do a global longitudinal strain and see. If it is abnormal, then maybe you decide not to stop the therapy. But as far as patients who are concerned, I don't know how much will it help in changing the therapy or something like that.
And do you see any cases of apical cardiomyopathy very often in India?
Yes, sir. Yes, sir. Apical cardiomyopathy is common, sir. We have in our cohort, we have well over 100 patients with apical cardiomyopathy. And
different?
So most of them are benign, but there is a form of cardiomyopathy that is not truly apical. That is a little beyond the apex. It's in the mid cavity, a little distal to the papillary muscle. These patients develop an aneurysm at the apex. So there's a mid cavity obstruction and an aneurysm at the apex. And these patients are probably at higher risk for sudden death. But I think the apical cardiomyopathy, they are said to be benign, but they have to be risk stratified in the same manner as one would do hypertrophic. If they carry on any of the high risk factors, like if they have syncope, if they have family history of sudden death, then probably you would risk stratify them in the traditional manners.
this question, I think, almost been covered.
Yes. How to proceed for genetic testing and how to approach which sample is required. Now, genetic testing, now we must do by the next generation sequencing method. The cost is really coming down. Like if we do in-house for whole exome sequencing, it costs us between 15 to 17,000, somewhere around that. So we have two options. One is to use a traditional panel. A panel, the advantage of panel is there's a cardiomyopathy panel. Most of the companies that carry out this sequencing, they have their own panels which cover almost all the genes. The advantage of a panel is that for a clinician is that I think there's an echo from somewhere. I'll just request everyone to mute. Yeah, that's fine. So the advantage of a panel is that the data that we get out of it is limited. That means only some of the selected genes are screened. So the graphs that we get, a lot of unnecessary data that we get is not there. So as a clinician, probably doing a panel is better. But if we are doing it from the research point of view, doing a whole exome is better, because we get a lot of sequence variations, but it's a headache to analyze those sequence variations. So if you're doing it as a clinician, you can do a panel. That should be doing a cardiomyopathy panel, and they would come up with whatever other known pathogenic or mutations that you would get. One would expect to get around mutations in around half the patients. These are commercially available.
Dr. Bahl, it is a very nice talk from you. A basic work has been done. I just wanted to know if the genetic testing is negative, do you want, we need not follow up these patients at all? Those who are negative in the family. Genetic testing is negative, yes. But yeah.
Right. Sir, in the family, let us suppose we have a known pathogenic mutation in the proband, and the family member does not carry the mutation. That family member and his children need not be screened. But if there is a doubt whether this is a disease-causing mutation, then we cannot be certain. So if we have identified the mutation in the proband and we are certain that this is a pathogenic mutation, then and the relative does not carry the mutation, then we need not do any further screening. But if there are a lot of mutations which are doubtful, which are of uncertain significance, so in that case, we still need to screen the relatives. So we would get pathogenic or likely pathogenic mutations only in half of HCM patients. So in these patients, we need not screen the relatives.
Thank you. And another question is, when they are genetically positive, phenotypically negative, I think probably still we have to carry out certain tests like imaging studies, like maybe CMR or STS protein, all these things. Just
yes,
to, yeah.
Yes, sir. So actually, to say phenotypically normal, we have to do two things. One is the ECG is normal and the imaging is normal. So traditionally, we say the imaging is echocardiography. Today, MRI is available. And if we see that the ECG and the MRI is normal, so ECG is normal, imaging is normal. So imaging today's time ideally should be an MRI. So if both are normal, then these patients are not at risk for sudden death. So far, no sudden death have been reported in very large number of mutation carriers. They need to be followed up for development of disease.
Thank you. Thanks. Any other questions from others, postgraduates? I think it's a very nice talk. We learned a lot from you.
Thank you, sir. Thank you, sir. Thank you for the opportunities. Thank you. Thank you.
Dr. Iyengar, anything? I request you to conclude, sir.
So I think it's muted, sir. So yours is, yours is muted.
Sorry.
Sorry.
You have given us a lot of useful information with a lot of your original work. So it's really impressive. And it's important that you should have clinical perspective of your genetic studies. Thank you very much, Dr. Ajay. Thanks a lot.
Thank you, sir. Thank you.
Thank you. Good night to you.
Good night. Wow.
Good night, sir. Thank you.
Thank you.
Thank you.
Good night.
Good night, Dr. Patil.
Thank you, sir.
Good night, officer.
Good night, sir. Thank you, sir.
Good night.